Good afternoon. It's my pleasure to introduce Dr. Vijayaraman as our grand speaker today. Dr. Vijayaraman is a professor of medicine at the Geisinger Commonwealth School of Medicine, and he also is the system director for cardiac electrophysiology for the Geisinger Health System. Dr. Vijayaraman graduated from Madurai Medical College in Madurai, India. Then he did his residency at the Albert Einstein College of Medicine in New York, followed by fellowships in cardiology and cardiac electrophysiology. Subsequently, he was recruited to Virginia Commonwealth University. He led the VA electrophysiology program for a number of years. Subsequently, he joined the Geisinger Health System as the system director, where he also serves as the fellowship director of the cardiac electrophysiology program. Dr. Vijayaraman is leading the way in conduction system pacing. This is critically important in improving the care of patients with heart failure. This is a groundbreaking new approach for cardiac resynchronization therapy and might replace CRT treatment in the future. He has contributed over 207 publications in this field and a true leader in this area. He has been recognized with several very important honors and awards, as well as he's been a highly sought after speaker both internationally and nationally. We are very pleased and privileged to have Pugal here with us. Thank you, Pugal. Looking forward to your talk.
Thank you, Hakan, for those kind words. And it's really a pleasure and privilege to be here. I did my fellowship and watched all the important publications in electrophysiology come from University of Michigan with Hakan and Fred Morardi leading the way for many years. And so they've been a true inspiration for me when I began my career. These are my disclosures. So I'll start my presentation beginning with my experience. So I just moved from Richmond, Virginia to Geisinger in Pennsylvania, which was primarily a rural, semi-urban population. And I was kind of bored trying to do things that University of Michigan did, and I didn't have enough patient volume at that time. And this was one of my first experience in the first year that I was there, a patient who had persistent AF, bradycardia, LV ejection fraction was 40 to 44%. He had periods of tachycardia, so he was referred for a pacemaker. And I had a lot of time in my hand, and I was bored. So I just read a paper on hisbundle pacing, so I decided to do a hisbundle pacing. And so this was my patient at that time. And I was very surprised by how easily I could get the lead in the hisbundle region and completely reproduce the same electrical activation. And also cardioverted him at that time. He was in AFib for a year or so and cardioverted him. This is almost 12 years later when he came for a generator change. He had still maintained sinus rhythm with a little bit of antiarrhythmic therapy in between. And his LV function had normalized. So that was it normalized within a year, but he was able to maintain conduction system capture and able to pace. So this was the beginning of a very difficult journey because I didn't realize how hard it would be to do hisbundle pacing in every patient. But we persevered and we were able to do it. The reason for that is if you think of right ventricular pacing and the activation is not normal. So you're creating an artificial electrical activation starting from the apex, very slow cell-to-cell myocardial activation, unlike the very rapid highway activation of the His-Purkinje system. But that's like giving an artificial limb to somebody and trying to replace a normal system. It's functionally very good. But physiologically, it didn't work as well because the result of this, you can see that there's quite a bit of acute and chronic effects of RV apical pacing. If you look at pacing-induced cardiomyopathy with just a very limited vision of looking at only patients who have decline in LV function, that may be 10 to 20% over 3 to 4 years. But most of these patients suffer from a lot of issues, develop early heart failure, even with preserved ejection fraction, heart failure hospitalization, atrial fibrillation, abnormal biochemical parameters. So the true incidence of pacing-induced dysfunction can be much more than what we actually get to see. And some of them may take many, many years to develop. So just to give you an introduction of His bundle pacing, early on, His bundle pacing was performed by targeting the His electrogram using a mapping catheter from below and trying to place the lead in that direction. The reason being, His bundle is a small region. It's about 1 to 2 centimeters in length and about few millimeters in width, and it lies across the membranous septum. There's an atrial component and a ventricular component of it. And if you look at the anatomical structure, that's a small strand of region of His bundle. Is that right? So if you zoom up a little bit more, so that's what we are trying to place in a moving heart with no mapping system or anything. Just you have to use electrograms and place the lead. And sometimes His bundle is not superficial. It could be deeper. And there's so much anatomical variation that makes this procedure somewhat challenging. And it's also surrounded by membranous tissue, so not enough myocardial fibers. Sometimes there's a lot of atrial myocardium, ventricular myocardium. Depending on where in this region you place the lead, your pacing characteristic changes quite a bit. So His bundle pacing, while it had its ups and downs over the 20-year period, people gave up the challenge of doing His bundle pacing over the years. But the idea of reproducing normal electrical activation and restoring not only depolarization, but also repolarization has its advantages. While His bundle itself was not something new, it was known for more than 50, 60 years, His bundle pacing first came in the year 2000, first publication. But initial attempts were done in the 1990s in dogs and animal models, but never materialized until this publication was presented in Circulation, a series of 12 patients undergoing AV node ablation, able to place a reshaped stylet with the active fixation lead, finding his electrogram and placing lead. It was quite challenging, took 3 to 4 hours, like our old AFib ablation days. But subsequently, tools had come along which made the procedure a little bit better. So our experience, His bundle pacing success was about 70 to 90%. There was difficulty in fixation in 10%. There were some patients needed higher pacing outputs. And so some of these challenges pushed physicians away from His bundle pacing, and also pushed investigators to try and find a better source. One of those was left bundle branch or LV septal pacing by advancing the lead deep in the septum from the RV septal side to get to the LV endocardial surface and get into the left conduction system. This has several advantages because unlike the His bundle, the left bundle is in a myocardium-rich environment. So there's almost always good myocardial capture. So safety is less of a concern compared to His bundle pacing. And then the second thing is most of the conduction disease, AV block, bundle branch blocks, all of them happen in the main His bundle. If not the proximal, but at least the distal His bundle. So you can pace beyond the site of the conduction disease in the vast majority of patients. And so this way, this led to change of paradigm from moving from His bundle pacing to left bundle branch pacing. We had a lot of discussion about which is easier, which is difficult, which is more nuanced, but we won't get into the details. But nonetheless, the conduction system pacing, both His bundle and left bundle branch pacing, are available for us to exploit for the benefit of our patients. And the reason left bundle branch pacing got more attraction and more traction in the communities because unlike His bundle, which is a tiny little area, left bundle is a much wider target, so it's possibly easier to get into the system in majority of the patient. And as you can see, our approach, the limitation being we don't know where on the other side the left bundle. We have to guess based on the right side, based on the anatomical course of it, and try to advance the lead deep into the septum and get into this main trunk of the left bundle. It's also morphed into trying to find fascicles, if not the proximal region, anywhere in the conduction system, because the left bundle Purkinje network is a very extensive network, well interconnected. So you can overcome some of the limitations, even if you're pacing distally, can get into the conduction system more. So now moving on to the role of conduction system pacing, how do we use these pacing techniques? So I look at it in two particular paradigms. One is our goal is to maintain the synchrony, someone who has AV block or who undergo AV node ablation. So you want to keep the narrow QRS normal conduction. Or those who have developed disease in the left bundle, right bundle, or mixed conduction disease and heart failure, you can restore synchrony to those patients. And the type of pacing should be determined based on where the site of conduction disease is and what type of pacing parameters you get. Now you have a choice. And sometimes we like to combine his or left bundle pacing with coronary sinus pacing to maximize the methods and techniques that we have. So we were able to use his bundle pacing to show that compared to patients who undergo right ventricular pacing in a two-center study within our health system, where in one hospital, every patient underwent permanent pacing with his bundle pacing, while my colleagues at my sister hospital performed RV pacing. Over a period of 3-year follow-up, we were able to show that the incidence of death, heart failure hospitalization, or need for BiV upgrade was significantly reduced. And similarly, we were able to reproduce this in another study, in a two-center study from Rush Medical Center and Geisinger, showing that even left bundle branch pacing can have similar benefits compared to right ventricular pacing. So how do we apply this? And we were able to look at a series of patients with AV block, high grade or complete AV block, and a significant percentage of 55% of them were at the AV nodal level. So here you can decide whether you do his bundle pacing or left bundle pacing. But then those patients who present with wide QRS or so-called HV block, we're able to identify that the vast majority of them, close to 90% of them, we were able to prove that the disease was intrahisian, either because they're narrow QRS and a HV block, his bundle to ventricle block, or you pace the his bundle and you're able to correct them, or often we identify split his signals in these patients. Or we go to the left bundle and find that the left bundle potential to the QRS and pacing is shorter because the rest of it is normal. So this way we're able to demonstrate that the disease is almost always intrahisian in vast majority of the patients. And occasionally we did find a certain number of patients where the disease was well below the his bundle. This is one such example of patient with high-grade AV block, 2-to-1, pacing the atrium here. This is a left bundle potential recorded here. And we're able to show that there's 2-to-1 left bundle to ventricle block. So there's diseased system here. And so that type of patients were about 4% in this series. Here's the other patient who had white QRS escape with them, but the potential to QRS timing is very long, so very diseased system. And in a small percentage of patients, we were unable to identify where exactly the conduction disease was because we didn't get all of the recordings through the routine methods. But nonetheless, LV septal pacing, left bundle branch pacing, or his bundle pacing was successful in 97% of patients. Just giving you an idea that almost all of these patients, you can get into the conduction system or close enough to the conduction system that this should be the universal method to pace when someone needs ventricular pacing. And this is a small study in our center looking at about 370 patients, those who had his bundle or left bundle pacing. There's no significant difference in the incidence of death or heart failure hospitalization. Again, both techniques seems to be equally effective in preventing, at least in this short follow-up. But now we have more evidence. This was early on, this was 1, 2 center, a few center studies. Now, conduction system pacing has caught on quite a bit in the sense that recently we're able to look at the Medicare database. And here's a series of patients who had Medtronic pacemakers because they had access to this data. So about 24,000 patients, 17,000 patients with dual chamber pacemaker, and about 6,000 patients with conduction system pacing, predominantly left funnel branch area, and remaining were his bundle pacing. And in this cohort of patients, we were able to show that the incidence of death or heart failure hospitalization independently was significantly reduced with conduction system pacing, even at 6 months time period. So you have evidence that you can reduce in a large scale heart failure hospitalization or mortality very early on. Imagine this benefit extending in the long term. And there are other studies that are coming out soon, 1 and 2 year follow-up showing similar benefits continuing in the long term. What we don't know is that this is a selection bias or is it true benefit? We need randomized trials to prove that. There is an ongoing trial of 2,500 patients from UK that's exactly testing that his or left funnel pacing versus RV pacing in patients with ejection fraction above 40%. So that's the bradycardia patient. So you have a lot of work that you can do to prevent heart failure. You don't have to wait for heart failure to develop, then go correct it with BiV pacing or conduction system pacing. But where are we in terms of cardiac resynchronization therapy? So currently we know we can correct left funnel branch block or white QRS patient with biventricular pacing. And it has huge benefits, 2 decades of data supporting that. And we have mortality benefit in this sick heart failure population. But think of this is RV endocardial myocardial pacing and LV epicardial pacing. That's totally opposite of what normal electrical activation is. Despite that difference, this works. But it also gives us an opportunity to improve outcomes in this group of patients because you don't have to settle for something less, even though it works well, where you can overcome many of the disadvantages of BiV pacing. If you look at BiV pacing, in patients with left bundle branch block, not every patient gets complete electrical resynchronization. We almost always leave something on the table because we are limited by where the anatomy is, where your veins can take you, and depending on how delayed that activation is there, sometimes limited by phrenic nerve or scar. On the other hand, if you have a narrow QRS patient who need pacing, you're going to lengthen the activation time. You are introducing new element of LV or RV dysynchrony in them. So you have opportunity to improve on those patients. And no wonder in BiV pacing, there is a certain, people can debate what percentage of patients don't respond to BiV pacing. It can vary from 20 to 40% depending on what metrics you use. But nonetheless, there's a good number of patients that don't benefit well from BiV pacing. So we have an opportunity to improve on those things. So as we know, there are several challenges with BiV. And almost all of the trials have shown that there is limitations to biventricular pacing in terms of adverse events, lead dislodgement, and complication during implantation. And the success rate can vary depending on it can be 15% failure rates to 3% depending on different studies. And even very early on, this was recognized that LV endocardial pacing is superior to coronary sinus epicardial pacing, both animal studies and human studies. So as an extension of that, we were able to explore, can we use conduction system pacing in left bundle branch block patients? So here's a patient with left bundle branch block. One of my early experiences with left bundle branch block patient. His bundle pacing can see complete narrowing and normalization from 190 milliseconds to 95 milliseconds. And that's achievable with his bundle pacing. In studies, they've looked at LV mapping, septal mapping with multipolar catheters to identify where is the exact site of block. This is a series of patients that presented to the University of Chicago, a lot of patients for CRT and a good number of patients for VT ablation who had left bundle branch block type morphology. They were able to show that 2/3 of the patient, block was in the either distal His or the proximal left bundle, and most of them could be corrected. And there was a third of patients with so-called IVCD, which has intact Purkinje activation, but slow and delayed activation. Those patients may not benefit much from conduction system pacing with the diffuse disease. But this number is a little bit skewed because there's a lot of VT patients who are sick and who had advanced disease who are on amiodarone or antiarrhythmic therapy. So here is how a patient with left bundle branch block. This is septal electrograms, His bundle potential, no Purkinje activation pre-QRS because it's cell-to-cell myocardial activation. So when you do His bundle pacing there, you can restore conduction through the His Purkinje system. That's proof of concept that the block is proximal and you pace and recruit the tissue and you can restore it. And same thing can be done by left bundle branch pacing. Here's the lead in the left bundle, and you can see same degree of left bundle branch activation as you stimulate the left bundle, so we can restore normal activation in these patients. This is a very elegant study from Imperial College looking at LV activation time and acute hemodynamics in a set of 18 patients with left bundle branch block referred for CRT. They did His bundle and BiV pacing and did body surface ECG mapping with ECG imaging, it's called, 256 electrode, like a vest on the surface. And looking at the activation, you can see His bundle pacing is complete normalization of activation, all the delayed activation. BiV is an artificial form of improvement. But if you look at individual patient, intra-patient comparison, the overall QRS duration, LV activation time, reduction in dyssynchrony, all reduce on top of what could be achieved with biventricular pacing. So you can get more from same His bundle pacing compared to BiV pacing and resulting in greater hemodynamic improvement, at least in the acute studies. Is a similar left bundle branch pacing, a lead, and 3D activation mapping showing activation here during left bundle branch block and then during left bundle branch pacing that you can restore normalized activation pattern in these patients. Another study looking at body surface mapping in a simplified ECG belt, LV septal pacing, His bundle pacing versus BiV pacing. So His bundle or LV septal or left bundle branch area pacing can result in similar acute hemodynamic benefits and electrophysiologic effects. So there's a lot of rationale for why conduction system pacing can be better than biventricular pacing. And what about right bundle branch block? We know from multiple trials that the right bundle branch block patients don't do much better with biventricular pacing. Here's an example of a patient with the right bundle branch block trying to apply the same concept as left bundle branch block. Good number of right bundle branch block also is in the main His bundle, not in the periphery. So here, pacing in the His bundle, you can see complete normalization of the QRS. There's a little bit of a non-selective fusion with RV septal capture in addition to the His bundle capture. At a lower output, we selectively capture the His bundle and complete correction of the right bundle branch block. And this is capture of the right bundle alone with resulting left bundle branch block pattern in a patient with a chronic right bundle branch block. So again, proof of concept that you can correct right bundle branch block. And we can do the same thing with left bundle branch pacing. Although left bundle branch pacing causes RV delay, so here's a patient with right bundle branch block. So you pace left bundle, you almost always capture the left bundle and the LV septum. And so you not only have conduction normalization or maintenance of LV activation, but transseptal conduction get to the RV faster. Or you can capture with the ring electrode. We can capture both sides of the septum, and this is that effect reduction of the QRS duration from 150 to 124. Not as elegant as His bundle pacing, but still the advantage is you don't cause new dyssynchrony on the LV side. And if anything, you can improve the RV synchrony to some extent. And so that's a possibility in patients with right bundle branch block. Then you have patients with IVCD. We talked about diffuse conduction disease, or many patients who have mixed conduction disease. Here's one such patient. This is a fast sweep speed, 210 millisecond, very wide QRS. And his bundle pacing is selectively capturing, correcting the left bundle branch block, but still has a 140 millisecond delay, QRS widening. That itself is an indication for BiV pacing, is that right? Now you combine that with LV sequential pacing. Now you went from 210 milliseconds to 110 milliseconds. So you can maximize your electrical resynchronization by combining these techniques. And same thing you can do with left bundle branch pacing. So his bundle pacing, another 210 millisecond QRS narrowed to 150. Left bundle pacing result in somewhat wider QRS, but combining with LV pacing, here you can further reduce the QRS duration and activation. So try to give the best possible electrical resynchronization in a particular patient. The 3D mapping of the same patient with left bundle pacing versus combined LBBB method. So we're able to show that in a series of patients, compared to native, BiV pacing improves QRS duration. His bundle pacing has a little further improvement in this advanced heart disease patient, but heart CRT or large CRT, combining his or left bundle with CS gives us the maximum. So incremental benefit for electrical resynchronization in these patients. So where are we in terms of clinical outcomes in CRT patients with conduction system pacing? So early on, these were observational experience, selected patients with left bundle branch block, dilated cardiomyopathy. This was experience from China, and was successful his bundle pacing about 76% of the patient. His bundle pacing resulted in almost 80% normalization of LVEF in patients with dilated cardiomyopathy and left bundle branch block, non-ischemic patients these were. And similarly, we were able to show a somewhat improved outcome with left bundle branch pacing. It was an early effort in trying to understand, can we use left bundle branch pacing? And so these were then tested in small clinical trials. HIS-sync was a very early attempt prior to left bundle branch pacing. And there was a lot of crossover and not understanding which of the patient you should do. But still, his bundle pacing performed as well as BiV pacing. In some regards, maybe better than BiV pacing. Another randomized study, 50-patient study, success rate for his bundle pacing was less, but overall outcomes were better with his bundle pacing. Not strong enough evidence for everybody to do his bundle pacing. Then this was a recent left bundle branch pacing pilot trial, 40-patient study showing greater benefit. Now we are moving into a territory of can we do better than BiV pacing, greater improvement in LV function. And recently, this particular study was presented in the APHRS in Sydney, a 200-patient randomized study from China, 100 patients for left bundle pacing and 100 patients for BiV pacing, and showed that the response rate at 6 months and the last follow-up was much greater with left bundle branch pacing, especially for super response rates, 65% versus 44% of BiV pacing, and also improved death or heart failure hospitalization endpoint compared to BiV pacing. We know we have a very high bar with BiV pacing, but if you can do better than that, then that's the way to go. So how about right bundle branch block? We still only have observational experience, multi-center, small series of patients showing that we can improve LV ejection fraction in these patients, both by his bundle pacing and also with left bundle branch area pacing, improve QRS duration, LV function, and functional class. There is an ongoing randomized clinical trial almost near completion. It's called HIS-CRT, 120-patient study randomizing between conduction system versus BiV pacing to see which should be the one to do in patients with right bundle branch block and heart failure. What about combining the two? This approach also seems to have good improvement in EF in both approaches. Early comparison studies are ongoing, and there is plans for some randomized trials. And industry is quite interested in doing that because with new technology and tools available, these are many, many patients, a lot of observational, early randomized trials. Now we are developing more evidence for using conduction system pacing as a first line. We're not there yet, but there is more evidence to support the hypothesis that conduction system pacing should be a first line and BiV as your backup. But that's our goal to get there. So we looked at this in an observational series, two-center study, looking at death or heart failure hospitalization, those who underwent BiV pacing versus conduction system pacing, greater improvement in death or heart failure hospitalization. And similarly, greater improvement in QRS duration and LV ejection fraction in all comers, as well as in patients with left bundle branch block, where you seem to expect to get the most benefit for BiV pacing. In those patients, conduction system pacing clearly does better. And there's another series reproduced from a 4-center prospective study, similarly showing greater benefit in terms of death or heart failure hospitalization, but more of an observational study, non-randomized study showing greater outcome. And we looked at a larger population, 15-center left bundle branch pacing versus BiV pacing. Again, similar signals showing that greater benefit for death or heart failure hospitalization on top of what could be achieved with BiV pacing. And so these results are more and more encouraging for us to continue, because you can get greater LVEF improvement, greater echocardiographic response. And these outcome differences, interestingly, the main difference between BiV and left bundle branch pacing was seen in women, where we generally get greater benefit with BiV pacing. And conduction system pacing seemed to perform even better in women. Unlike in men, the difference was minimal or non-existent. So recently, we presented the results of additional benefits of conduction system pacing. If you think of conduction system pacing, you not only improve depolarization, we improve repolarization. So can that result in benefits in terms of reducing VT-VF? We're able to see a clear signal that the new onset VT-VF or needing ICD shocks were significantly reduced in patients with left bundle branch pacing compared to BiV pacing. In some patients, we know that BiV pacing can be proarrhythmic because you're near the scar zone, you can create and enter into a unidirectional block and create VT-VF. Another benefit was we also saw that the benefit of improved LV function is reduction in atrial fibrillation. So again, additional benefit that can help us. Now there are more meta-analysis of all of these, both randomized and non-randomized studies showing that you have improvement in death and heart failure hospitalization independently. So there's room for randomized clinical trials to show that we can do better. What about patients with LVEF 36 to 50%? This is a mid-range group. BiV pacing is still a class 2B. And can conduction system pacing do well in that group of patients? So again, we saw a similar signal in terms of death or heart failure hospitalization. Conduction system pacing can perform better than BiV pacing in this population also. And most of these benefits we find consistently come from reduction in heart failure hospitalization. So what do we do in our health system? Because you have so many options and different physiology. So one particular approach may not fit for every patient. So our approach is to be very specific for underlying conduction disease. So if someone needs ventricular pacing, resynchronization, but have narrow complex, we start with his bundle pacing. And if we can get really good thresholds, acceptable, our standards have changed. We've got very rigid criteria over a period of time with availability of left bundle pacing. If you can get a good threshold with his bundle pacing, then you go to left bundle branch pacing and try to get maximum electrical normalization. In patients with wide QRS, we start with his bundle pacing. And if we get complete correction, then we do left bundle branch pacing because we get good thresholds with left bundle branch pacing. So we prove that we have left bundle branch capture. If we don't have left bundle branch capture or our electrical synchronization is not adequate, then you move on to combining these two approaches. As in this patient with a wide QRS, you add, in addition to left bundle pacing, you combine with coronary sinus pacing. And we tested this in a randomized clinical trial. So we had a 100-patient study, 50 patient randomized to conduction system guided approach versus BiV pacing. And we were successful with BiV pacing in 82%. I was worried that we'll fail more in his bundle or left bundle pacing because of our early experience from his sync study. But we realized quickly that our colleagues, this was a single center, 8-physician study, and most of them were ready to give up on BiV pacing and move to conduction system pacing because they wouldn't accept any suboptimal placement of a coronary sinus lead. They wanted to get the best result for the patient. There was more crossover from BiV to conduction system pacing, and conduction system pacing was successful in 96% of the patient. And so this approach, we're able to show that, the success rate of 82% versus 96%. So it is practical, it's doable in almost all of our patients. And the endpoint was change in LV ejection fraction. This was a 6-month study. So we were able to show 12% improvement versus 8% improvement with BiV pacing. And so I think this is a very nuanced approach, and one size won't fit all. And this is what we would advocate, but it may be challenging to do. But it's something that I think we should use. The result of all of the work from our group and many other groups around the country and around the world has resulted before large randomized trials were done, forced the society to come up with guidelines for pacing. So anybody who needs ventricular pacing based on LV ejection fraction. Now, conduction system pacing has a class 2A or 2B indication in the majority of the patients. How about heart failure patients? Now, it's a little bit nuanced. If you don't get good BiV, effective CRT cannot be achieved. That's left to your discretion, looking at various parameters that helped us define BiV pacing. Move on to conduction system pacing quickly to get us better results for those patients. And this approach is available for all aspects of CRT requirements at this point. I don't want to go into the details of that, but guidelines are published now. And now we have quite a few randomized clinical trials ongoing for both the narrow QRS or wide QRS patients with reduced EF or normal EF patient. And one of those trials is left versus left trial, which is a 2,100 patient PCORI funded trial looking for a hard endpoint comparing BiV versus conduction system pacing. But it's going to take another 5 years for us to get the results. As well, more than 25% of patients have been enrolled. Hope to complete enrollment by next year, and then 5-year follow-up. Maybe we'll stop the study sooner if the results are positive. And here are my final thoughts. Conduction system pacing is safe and feasible. And it's elegant in its simplicity in trying to repair the existing conduction problem rather than replace it with artificial and suboptimal conduction. And so it's time we reinstate physiology in pacing. And thank you very much.
Thanks so much, Paul. This was fantastic. This is a rapidly evolving field, but as usually is the case, there usually is a gap in timeline between the guidelines and as the results of the randomized clinical trials and sufficient data build up to change the practice patterns. So currently, do you routinely implement a conduction system pacing lead when you have a direct indication for CRT implantation with good outcomes as a backup in case CRT was not sufficient download?
Yeah, so when I first started doing it, we were doing it only for those who failed or those who were not getting good results with BiV pacing. But over a period of time, all my colleagues have shifted to going direct to conduction system pacing for CRT. And the challenge there is that while, as we were talking this morning, his bundle pacing is very clear. You have conduction capture versus no capture. Left bundle branch pacing is more nuanced. And as we are building more evidence, we are finding out that LV septal pacing is not good enough. And so I'm trying hard to instill in our group that to confirm conduction system patient capture in every single patient that they're doing CRT to prove that that is the best approach. But if you don't have capture, or if you're doubtful, then definitely add a CS lead or move to BiV pacing quickly. And that's our goal, and we're trying to push the field forward.
It's fabulous. You've convinced me we need to do this. It's been a long time since I've held an EP catheter. It's very complex. It seems like it must add a lot of time to a procedure and can sort of everybody be trained. Seems complicated.
So his bundle is something most of the electrophysiologists are very familiar with. We know where anatomically it's placed. And while in the beginning it was thought to be an extra effort to do this, but now it's a standard workflow. We can get to the his bundle in a matter of minutes and fixing the lead. And the left bundle branch pacing is taken off more because you don't have to be as precise in your placement. And it's made it easier to get into the left bundle branch area. So the time-wise, more and more studies are showing that we can do it faster than BiV pacing.
Thank you. Thank you for telling me the scenario. And then one final question. Just because of its anatomic location and the angle, do you end up with more tricuspid regurgitation than you would with RBBB?
Yeah, so great question. So we've looked at it right from the beginning when we did his bundle pacing. That was a huge advantage. Was like promoting it, saying that you don't even cross the valve. His bundle pacing is so much better. You don't interfere with the tricuspid valve. So that was true. His bundle pacing, we didn't see worsening of tricuspid regurgitation or anything. So when I first started doing left bundle branch pacing, my biggest fear was, can we fix the septal leaflet and cause severe TR? So we looked at echocardiography routinely in every single patient that we did the initial left bundle pacing, immediate post-procedure, and made sure we have some methodology that we would avoid any of those things to happen. We only saw one patient with worsening of tricuspid regurgitation acutely in our study because we were paying a lot of attention to it. But lots of series have been published now looking at tricuspid regurg. So there are some studies suggesting that more proximal you place the left bundle branch pacing lead, there's slight worsening of tricuspid regurgitation. And some of those groups advocate to place the lead more distally. That's not my experience. We are looking at it in our several hundreds or close to 1,000 patients. What is the incidence of tricuspid regurgitation compared to BiV versus thing? So hopefully we'll get you an answer. But if your implant technique is focused on avoiding tricuspid valve, then the risk of tricuspid regurgitation is smaller.
I'm not questions for Dr.
Explaining more about the gender difference.
Yeah, so what we looked at is in that series of 1,700 patients, tried to understand where electrical resynchronization makes a big difference. Historically, BiV pacing is more effective in women than men. And part of it may be because of the QRS is not that wide in women generally, and any electrical dyssynchrony makes them worse. And my hypothesis is that conduction system pacing gets you greater electrical synchronization, so more bang for the buck. So that those patients improve much better than men. Just a simplistic view of thinking.
Well, you see the difference only in left bundle branch block, not in right.
Yeah, so those patients are predominantly left bundle branch block. So we don't have enough numbers to say that difference exists in the right bundle branch block. So we don't know that yet. Hopefully, his CRT is only a 120 patient randomized trial. We'll see if we can find any answers to that question in that population.
Good. Thanks so much.
Thank you.